This study is about the fixed dose capecitabine in 7 by 7 schedule compared to the standard design in metastatic triple negative metastatic breast cancer. We know that capecitabine is a oral fluoropyrimidine which is patient friendly in the sense it is available in oral form, no need of admission, and the chance to have hair loss is less. But it is a bit difficult in real world scenario because of cumulative toxicities like hand-foot syndrome and GI toxicity. Various models are saying that by changing the schedule and by changing the doses, instead of going with a standard dose 1250 milligram per square meter, reducing the dose may reduce the toxicity arm, but without affecting the disease-related outcomes. So the study was done in US, that University of Kansas City, where they recruited the metastatic breast cancer patients after progressing the initial systemic lines. Those who have HER2 positive, they allowed to take anti-HER2 therapy, and the renal function should be adequate. The creatinine clearance must be at least 50, more than 50. And they randomized to the fixed dose arm, that is 1500 milligram BD, 7 days on, 7 days off. And the standard arm, the another opposite is the standard dose, which is 1250 milligram per square meter BD, 14 days on and 1 week off. And they were followed for the capecitabine toxicity as well as the disease re-evaluation done periodically, every 3 months with the appropriate radiological investigations. The primary endpoint, 3-month PFS. The secondary endpoint include PFS, OS, objective response rate, and toxicity. So they have recruited 153 patients, majority are hormone receptor positive, of which the primary endpoint, the 3-month PFS, there is no statistically different between the two arms, and the PFS, OS at 36 months, there is also no statistical difference between the fixed dose and standard dose. But when you look at the toxicity profile, the grade 2 to grade 4 toxicity, there is 50% reduction happen in the fixed dose arm, and the toxicity related treatment discontinuation, it was 75% reduction in the fixed dose arm compared to the standard dose arm. It is pretty good values. So author concluding that it is a safer alternative option to minimize toxicity while maintaining the outcome. And we all know that any majority of our chemo drugs we are using in maximum tolerated dose. This maximum tolerated dose is developed in the phase 1 trial with small cohorts. Usually they used to give the drug and they will look for the dose limiting toxicity and generally 1 cycle. But the drugs like capecitabine, the real problem is the cumulative toxicity. It makes the adherence is very difficult. So the drugs like capecitabine, the adherence to the maximum tolerated dose is controversial, and we have to apply our real world knowledge to bring down the dosage, and alternate schedules are warranted. We all know that there is no single universal dose for capecitabine, which has various interpatient variations are there. And the Chinese, they have used capecitabine 650 milligram per square meter. And we have experience of using different dosage in metronomic. Even the small dosage like 1000 milligram BD, it produced good responses as metronomic here. So in Indian scenario, the schedule is okay. That 7 by 7 schedule is looking good, but 1500 mg BD, it may be still toxic to Indian patients. So we need our own data, which is the safest, that minimum effective dose for the capecitabine should be addressed. So with that, I am moving to the second study, which is the contralateral breast cancer risk calculation in the BRCA carriers. We all know that BRCA1 and BRCA2 carriers, they have the risk of contralateral breast cancer, which is around 16% to 45%. And contralateral prophylactic mastectomy, it reduces the chances of malignancy by 90%, we all agree, but whether it translates to survival benefit, it is highly controversial, and we have many talks in morning also. So we have to identify the right person to go for the contralateral mastectomy. For that, we need a validated tool. But unfortunately, so far we don't have any validated tool to calculate the contralateral breast cancer risk. So this study addressed this, and this is done in University of Peking, which is in China. And they recruited 10,000 odd consecutive CA breast patients, and they checked for the BRCA1 and BRCA2 variants. Pathogenic and likely pathogenic variants were included in this study. And they have detected BRCA1 and 2 in 491 patients out of 10,341 patients. And after giving the primary treatment, they were followed the patient with over the time. They had a median follow-up of 7 years, of which they have identified 66 events of contralateral breast cancer. And then they did univariate and multivariate Cox regression analysis of baseline characters with CBC risk, and they developed a nomogram, and further they validated the nomogram in an independent cohort of 205 patients. So these are the baseline characteristics of the primary cohort: the age at diagnosis, menopause, age at first birth, breast density, family history, BRCA variant, mutation type, mutation location, tumor size, grade, histology, nodal status, hormone receptor status, HER2 status, chemotherapy, endocrine therapy, anti-HER2, radiation therapy, and BSO. The notable parameters here are the majority are BRCA2 mutated. This is little surprising. We have limited data in Indian context, but with the available data, the most common mutation happened in BRCA1, especially in the breast. It is around 75%, but here the predominant are BRCA2. Second thing is the patients who had large rearrangement, which is just 5.7%. We don't know that whether the MLPA was done as a reflex in all patients or not. That data is not available with this paper. And majority are hormone receptor positive, as it may be because of that predominant BRCA2 status. And BSO was done only in 3.7%. We all know that BSO not only reduces the cancer ovary risk, it also offers protection in the cancer breast incidence as well. By merely doing a BSO, it reduces 75% of incidence of CA breast, especially in the BRCA2. But it was offered only in 3.7% patients. So with this, they identified 4 parameters as strongly associated with contralateral breast cancer incidence. With that, they have developed this nomogram. They offered the points 0 to 100 to age, family history, mutation location, endocrine therapy, presence or absence. With that, they have given the total points 0 to 160. The patient who has 160 points at baseline, she has 5-year cumulative 5-year contralateral breast cancer risk of 35% and 10-year risk of 70%. So this nomogram is validated internally by using a statistic called bootstrapping, and externally they have applied to around 200 patients of another cohort, and they derived these values. And these are some high-level statistics. I inquired a statistician. What he mentioned is, in these statistics, anything more than 0.6 is significant, and close to 0.9 is very strong correlation, and the values here are around 0.7, which is significant. So this is a useful tool to identify the risk of the contralateral breast cancer in the BRCA carriers, and it may assist the clinicians to identify the strategy for the risk reduction. But my thought is the sample size is less. especially it comes from the single territory. And here you can see that majority are BRCA2. This is not reflecting the real world scenario or Indian scenario. So how we can apply this to our patient, that is one thing. And the very small numbers in the large rearrangement. So if you have a patient with a large rearrangement, can you apply this?
Please conclude.
Can you apply this to that patient? It may mislead. So that is another issue. And the benefit of RRSO, and it was given in a very small population. So if your patient is willing for BSO, whether this risk calculation applies to that is also questionable. Nevertheless, it will give you an absolute risk score rather than giving a range to your patient.
Dr. Deenadayalan, you need to conclude now.